Good morning, dear friends. It's a great pleasure to be here with all of you in the Disruptive Medicine Forum, word of Latin origin, where it says it's a sudden rupture, a sudden change that leaves in bankruptcy other things we did before. Rupture, change, evolution, mutation, all those things that are synonymous or words that can say that there are new things, very new things, that we have to adapt to because we keep on evolving. And we will talk about disruptive medicine as something that is going to improve, to make us be better in the whole development and innovations and digitalization and disruption. What we are going to talk here about has a lot to do with it. And probably I'm going to talk about this terminological, stop talking about that because there are things that we will be hearing about this morning that I hope you will enjoy. I spoke another day with a psychiatrist. We work for people to enjoy. Don't you want to recover people? We do so when they are enjoying. So please enjoy this morning. Learn that this is the most important thing in life. Learn new things. To start learning, the best thing is to have somebody who knows a lot. That's why we have Iñaki, my dear friend Iñaki Ereño Irribarren, who is going to address a few words to talk about this disruption in medicine and other areas of our business, what that does mean. Iñaki, please, you have the floor.
Bueno, maestro.
Well, dear Maestro Fernando, thank you very much. Fernando, my dear friend. Good morning. Thank you for being here. It's an enormous pleasure to see you here today. Welcome to this Sanitas Forum, a classical meeting on the debate on the situation and the future of health. It's a very important event for us because this allows us to exchange opinions with the healthcare providers, with all those who, in one way or another, make up the Sanitas family. This exchange is allowing us to put our feet on earth. This is very important. Because this allows us to convey the vision of Sanitas on the world of healthcare. Last year, you will remember that. I've seen many faces that were here last year as well. We talked about what the digital patient was about and about the benefits of digitalization. This year, without losing the focus of the digital transformation and what it means, we're going to focus on disruptive medicine, as my friend has said. This disruption is a word that is not aesthetic. It's difficult to pronounce, by the way, and it also has some negative connotations. It's associated with breaking things, with chaos. But in Sanitas, we understand disruption in the positive sense, meaning of the word. We believe it's an opportunity to go ahead. The first thing we have to talk about disruption in the industry of health is that this has become the new standard or the new normality. This is a message that we will repeat throughout this day several times. It's like the theory of the black swans, these unexpected events that have a great impact on economy and society and happen more and more. With disruption, the same thing happens. It's more and more frequent. It's the seal of our time. Everything is more rapid as a consequence of the development of digital technologies. But disruption, we have always had that in the history of medicine. Disruption where, for instance, the introduction of X-rays, the discovery of penicillin, or the onset of endovascular techniques, in order just to quote some events that have changed radically the way in which we cure our patients. In this day, we are going to talk about new things as well, the disruptive things that are happening in current medicine that confirm that this is transforming in a very accelerated manner the care of health. We have very interesting interventions on precision medicine, on customized medicine, where we're going to talk about single and specific therapies in fields like dermatology, cancer, or rare diseases. We're going to hear about advances in artificial intelligence in radiology, therapy for neurological lesions based on virtual reality, or in personal genetics. But disruption is not only invent or discover things as X-rays or penicillin. As you also know, disruption can also be discover new ways of working, find methods or procedures to use techniques and therapies that already exist, but in a more practical manner and an easier use of them, causing a better access to the healthcare. That's what Anglo-Saxons call connecting the doors. We in Bupa connecting the dots, but it's because it's connecting or relating the new technologies with the healthcare providers and the patients. This is also disruption because it allows to improve the quality of the health services and thus the experience of the patients. In this setting, this disruption as a new normality and the need of having bridges between the different techniques and the patients and professionals, we are changing our way of working in Sanitas, and we have started several innovations that can be considered disruptive. I'm going to point out 3 of them. The first one, we have opened a new communication channel between physician and patients with the digital consultations, with our consultations through video, voice, and chat that are a breakthrough experience in the delivery of health services. We have more than 1,000 actors of all the medical specialties. And as we are already achieving 2,000 video consultations per month, and we have 300,000 customers that are on board. It's very important to count on you, the physicians, for this whole project. And I'm very grateful to those that are already on board. Many of you are in the waiting list. You are asking to enter. I thank this enormously because we need your trust so that this happens. We are making a protocol of recommendation for the use of video consultations that is pioneer in the world. Maybe I will seem somewhat arrogant, but it is true. It's our program of digital consultation. It's one of the most advanced that exists in the industry of care and not healthcare, and not only in Spain. A second initiative is what we call connected health. This is a platform linked to new devices, watches and bracelets or digital devices that the patients have on them that generate biometric information. This information is sent to the platform, and through big data and AI techniques analyze the data and monitor the health of the patient in real time. And this is fundamental to detect and prevent the risks, especially in patients who are chronically ill. Today, I have it there, Maria Jesus, we have 600 patients with whom we are working in the connected health program that are in this setting of receiving medical care, and we are just starting. And this is the project, the Sanitas, the Disruptive Project. As its name indicates, connects very well with the topic of this forum. Sanitas Disruptive has been working the whole year of encouraging digital talent, with which we have helped to develop 6 startups that use disruptive techniques in the world of healthcare. This initiative is focused on very specific areas of the industry of health, and it's a proof of our commitment with innovation. We know that we on our own cannot approach different projects, and we help others to develop their ideas. Several of these companies, of these startups, are here with us today, and they will tell us their experiences that are extremely interesting. The program has been very successful, and we are already preparing the next promotion that starts with the beginning of 2019. And we are also doing other things that have a great disruptive component, as the digitalization at 100% of relations with our patients. Today, a digital patient wants to get in touch with Sanitas totally digitally. He can do that already, or take the residential cares to the home care environment. But I believe that with the initiatives I've mentioned, it's enough to accredit, to tell you the effort that we are making in order to adapt to everything that is coming. I don't want to dwell more because the agenda is very tight today, but I would like to leave you with 3 ideas. The first one is that we've said that at the beginning, disruption is the new normality. This is so, and we believe there is no way back. And the progress of digital technologies can't be stopped, and its implementation in the world of health and medicine means an extraordinary change that makes our work more attractive, more fun, and more challenging. These are the great leagues in medicine, and we want to play in that league. And we are delighted and having a nice, very good time. And the second idea that I would like to leave you with, and the third one, that disruptive medicine is, in this case, is very interesting, in my opinion, because normally we go to the most sophisticated part, the most striking part, but also disruptive medicine. It's not only to discover new things, but also very important to discover new ways of doing things, new ways of using things that have been discovered time ago, and new ways of connecting patients with technology and the healthcare providers. And the third one is that Sanitas is implementing several initiatives of telemedicine as the video consultations, the follow-up of chronically ill patients with electronic devices, and many more things. And in fact, we want to share that with you as well, that we have a goal in mind. We think that we have done it well if in 2020 we have been able to have 25% of the consultations that the patients do in Sanitas with you are done in a digital environment, that 50% of the customers of Sanitas or communicate with Sanitas in a digitalized way completely. And if the NPS, those of you who maybe you don't know what it is, it's a measuring device of client satisfaction. All the greats in the world in different industries that have a very high NPS. We are all those of us who are very hooked on Amazon have an NPS of 75. That's what we want to be in 2020. It's very easy to remember. It's 25, 50, and 65. 25% of our digital, 50% of totally digitalized, 65% of NPS. How are we now? Consultation, not 25. We are just in 7. Digitalized patients, not 50, 35. NPS, we are not in 75, we are in 60, depending on the business unit that you deal with, a little bit more or a little bit less. So I just would like to tell you to close that we want to count on you. It's not that we want it, we need it in order to develop everything that we are setting up. Without you, the healthcare providers and the physicians, this is not possible. I've been 3-4 years with this event telling you this, but that's the truth. You are those who cure, you are those who save lives, and our work is to make your task easier. So thank you for your support, thank you for your attendance, and have a great day.
Muchas gracias, Iñaki. Yo creo que está muy claro.
I think everything is very clear. 100% of enjoy today, 100% of care, attention to see how disruption is already here, the new standard. Let's start. I'm going to, in less than 1 minute, we're going to have 2 panels. Both will be coordinated and moderated by people who really are very important in our organization. 2 disruptive people with different styles, of course. 2 disruptive people who are creative, who make things be better done, because there are disruptions that sometimes are very linked to what is negative. This is positive disruptions. We will start with the first one that talks about disruption for precision. Can we be precise disruptively? Yes, we will see in this first panel. I'm going to call on my boss and José Francisco Tomás, executive medical doctor of Sanitas and an excellent person who is going to moderate the first panel. And I'm going to call on the speakers that will be here. José Luis Jorcano, please. José Luis Jorcano will be in this panel as well as a speaker. José Antonio López Martín, and also my dear friend Gloria González, please come forward, because they are going to be with José Francisco. Then we'll make this first panel on disruption for precision. You have the floor.
Muchas gracias.
Thank you very much, Iñaki, for your words. And, well, I said before, well, my boss said that disruption is a word that is difficult to pronounce. And the first thing that comes to your mind is, as you are frightened. When you hear about disruption, be afraid. And here there are examples that disruption very often is only to think in a different way, differently. I'm going to give the example of the second part of the talk. Immunotherapy in cancer, this is closer to me. Since ever, we've known that people who had problems in the immune system had more cancer. In some time, some cancers were treated giving the BCG vaccine. People with transplantation who have a rejection didn't relapse, etc. We knew that. But we have to think differently, because very often disruptions is to think differently. The facts are there. Things, we have to know how to interpret them. One way of being disruptive is learning to think differently. And I think that here in different areas today, you are going to teach us to think in a different way. And we are going now with the first of the talks.
Aquí a José Luis Jorcano.
I have here José Luis Jorcano, head of the engineering, special engineering department and of the unit of TMAT. He's going to tell us about something that we always thought is somehow the possibility of creating tissue. He always had the challenge. There are challenges in the life. The challenge is to fly, to build, but another challenge is to create organs. We've always thought about the possibility, if we are able at some point in time, be able to creating organs, the different organs in our body. So please, I leave you with your talk, and thank you very much for being here with us.
Buenos días a todos.
Thank you. Good morning, everybody. I would like to thank the organizers for allowing me to come here to introduce our work in such a distinguished and important forum for us. And on the other hand, when I come to this podium, I realize this is quite interesting, thrilling, because as associate to Sanitas, I'm used to the Sanitas physicians. Now I have to learn to enjoy why when I was sick, when I go to the physician is on a pedestal, but now it's my turn to be here in front of you. Why do we enter this whole mess of generating organs, artificial organs, tissues and organs? In the world, there is a global demand for new organs. And this is so because now he managed. This is so because, as we can see, the waiting list of people who are waiting for an organ to be transplanted is growing much more rapidly than the list of donors. And although those data for the United States, they are perfectly extrapolated, can be extrapolated to Spain, in spite that, as you all know, we are the leader country in the world in organ donation and transplantation as well, or transplants. If we go to the field of skin, in which historically we work on, there are two areas where this demand is very important. On the one, of course, in the clinical application in the field of healing and paradigmatic in the treatment of the great burns. But on the other hand, although we are less aware of it, we have the field of the testing of pharmaceutical products and cosmetic products as well. The cosmetic products in Spain and Europe can't be tested on animals, experimental animals, since several years already. And the pharmaceutical products, although they can keep on being tested on animals, well, the experimental animals, the most common ones, rats and mice, the extrapolation of those results to human beings is very limited. So the entry of new drugs in clinical trials simply based on this type of trials, well, is quite dangerous. From the economic point of view, the treatment, the industry, the global industry of the treatment of wounds is in $20 billion per year, out of which $1 billion is already the market value of the artificial production of skin to be transplanted in patients. And although we are not aware of it, the market value of the testing of pharmaceutical and cosmetic products is similar. We talk about around $20 billion per year. Although from the ethical and sentimental point of view, it's much more attractive to work with patients from the economic point of view, and there are many companies that live with that, the testing market of drugs is equally important. So we are developing in the experimental labs new techniques that allow us to face that demand. And out of the two that are more in the front line, we're going to talk about the 3D bioprinting of tissues and organs. In reality, with 3D printing technology, we have 40 years of experience. And there are many different techniques in order to work with different types of materials, from ceramics, plastic to metals. And they are more and more, although we are not aware of it, we have more and more elements that we have pieces in cars and airplanes that are already made with 3D printing. This is just a printing based on layer deposition in order to be able to create 3D structures that can be very complex. And we are all aware that there are 3D printers that work fundamentally with plastic filaments that are already in the market. And for a value of 500 euros, you can buy a good printer to do many things at home or in the lab. Some time ago, from that point of view, the use of 3D printers has reached the field of medicine. We work fundamentally with plastic, and they are useful for many different purposes in order to make external prostheses, those exoskeletons, in order to allow the movement fundamentally to children who have different diseases that make them unable to move. And then we also have them in order to make what we call internal prostheses. This is the case of repair of a trachea. In the field of dental implants, this is very extended already, to do them with using ceramic material, to use the 3D printing for implants. And it also has the advantage that they are customized. Any technique of image acquisition takes an image of the tooth of the patient and reproduces it very accurately. Of course, in the field of prostheses, of hands and feet and legs, that more and more are more perfect and more functional as well. And another field where this plays also a growing role is in the pre-surgical models, or when the surgeons have to face an operation where they don't have too much experience in, or is a variant, a new variant, a new way of doing things, or it's a child and an operation with which they are not too acquainted with. What they do in many hospitals today, especially in the States, but also growingly in Spain, is to take an image of the organ that they have to operate on, a heart or a spine of the patient himself at real size, make a 3D printing, a real print of the organ with the dysfunction, and before entering in the OR, think how they are going to approach this intervention. This helps them to do that. But here, what we are talking about now, I have a problem with, in order to make the slides work properly. We are talking about a bioprinting, not just 3D printing, but bioprinting. These three letters, these bio, changes completely the concept of the printing. We are not talking about printing using plastic materials or metal materials, but using biological materials. And what we can do when we think about this technology is, what have we learned in the last 20 years through what have we learned in the recent 20 years with tissue engineering with respect to how to be able to build tissues and organs? We've learned that we need three fundamental components. Of course, the cells, without them, we can't think about creating any tissue. Less aware are we about the scaffolding that technically we have extracellular matrices that are sets of proteins and other factors that segregate by the cells of the tissue themselves, and that meet two roles. On the one side, they give the 3D form and shape and the mechanoelastic properties of the tissue. But apart from that, not only are they components, mechanical passive components, they also signal the cells how they have to perform in different occasions. So in reality, they are part of the functioning of the tissue, and then a whole series of different factors, growth factors, ions that may be necessary in order to make these tissues. As I told you, we are aware of the cells, but we are not that aware of the different extracellular matrices of those scaffolds. For instance, this is talking about human skin. This is the dermis. These are the dermal cells that are fibroblasts, and all this scaffolding that we see around that is so complex is collagen 1. And this is the extracellular matrix in which these fibroblasts are embedded. Collagen 1, as you know, is the basis of the mechanical properties and elastic properties that are so fantastic that the skin has. But as I told you, not only do they have those passive properties, but they also signal the cells how they have to work and how they have to react in front of stressful situations and healing situations, etc. Well, in this setting, that is organ printing, basically in organ printing is to use printers, 3D printers, in order to generate organs and tissues. And what is a 3D printer? From the philosophical point of view, the concept is practically identical to the one of the printers we have in our computers, with two differences. One, as their name indicates, they are 3D. They have to print in the three directions in space. They are not as our printers that only print in the XY plane. They also have to have movement in the Z plane in order to be able to deposit different layers. And the second one, from the point of view of trivial engineering, the second one that is the most important property is that whilst in the cartridges of our printers we have the 4 inks with the 3 fundamental colors plus black, that guided by the software of the computer are mixed adequately and are deposited adequately in order to give rise to something in color, a figure in color. In the case of a bioprinter, well, what we have in the cartridges are what we call bio-inks. The bio-inks is that what we have just seen. These are cells, extracellular matrices, proteins, growth factors, ions, etc., that we do require in order to generate the tissue. And that's where we have the problem, the core of this whole problem, in the bio-inks. Well, what were we doing? Why did we decide to enter the world of 3D printing? And I also say, what was the key of our success? We developed that very rapidly. Well, we answer this, and we have been more than 1 decade doing generate tissues and interfollicular skin. Interfollicular skin doesn't contain any of the appendices of the skin, follicles, hair, glands, etc. And this is just the basic component of the skin, the minimum one that we require in order to be able to live. That is a dermis and an epidermis. As you can see, this is in itself quite complex because these are two absolutely different tissues. The dermis has very little cells, and here we have the fibroblasts, and a great part of the dermis are elastic molecules, collagen 1, but also collagen 3, elastin, etc., hyaluronic as a hydrating agent, etc. Whilst on the other hand, the epidermis is a stratified epithelium in palisade with different layers that are born from the most basal layer, the only one that has the capability. The cells have the capability of reproducing and dividing, and when they divide, the two daughter cells. One stays in the basement layer in order to keep it complete, and the other one migrates to the upper part. And when they reach the surface, they die. And the remnants of those cells form what we call the corneal stratum, the membrane that separates from the outside world. That is very aggressive, by the way. Between the epidermis and the dermis, we have the basement membrane that is a complex structure whose mission is to maintain the two compartments of the tissue or the organ close together. So they have to be close together, not separated. And throughout a period of time of approximately 1 decade, what we did was to develop a method in order to produce great skin extensions in order to treat initially large burns. As we can see here, in a term of 3 weeks, we are able to go from a small biopsy of 1-2 square centimeters to the total body surface of a Caucasian patient who are 2 square meters. In order to do that, the method that we implemented from a small biopsy, as I said, with a standard method, we separate the two components of the skin, epidermis and dermis. We isolated their cells, fibroblasts of the dermis, keratinocytes of the epidermis, and with a small biopsy, we have approximately 1 million of each one of these cells. And here we have to make an expansion of 10 to the 5. So the first thing we have to do is to grow separately those two cell types until we reach that number, the hundreds of millions of cells that we do require in order to make this transplant. Once we have generated those cells, we proceed to reconstruct the skin in 3D. And in order to do that, what we use is human plasma. And what we do is we simulate the clotting or coagulation reaction, in this case adding calcium, because as it is human plasma, it has thrombin inside already. And this reaction is controlled. It takes a half an hour to form a clot. And during this half an hour, we introduce the fibroblasts, so that at the end of that period of time, we have a dermis that is reasonably solid with fibroblasts. And when this has already happened, we seed on top the keratinocytes, and we can transplant this on the patient. And in contact with the air, in the same natural position as the skin has in the human body, the dermis in contact with the wound, with the burn, with the surface of the wound, and the epidermis in contact with the air. The epidermis is differentiating and forms all the different layers that the epidermis has. The corneal stratum is bound to the dermis with the basement stratum, and we generate a product that when it's compared with normal skin, this has a different amplification factor, magnification factor, but when we use it the same, this skin that is the artificial one and this skin that is taken from a human donor, well, are practically identical. Well, this is the product. As we can see, it's a quite elastic skin that is easy to handle. And these are some examples. This is a transplant on the forearm of a patient. A forearm, from the topological point of view, it's flat. So it's a plane. It's not too complicated. We can suture it. We can staple it. But this is a transplantation on the hand of a child with epidermolysis, and we talk about a much more complex operation. But it's easy to handle. It can adapt to many different surfaces. This was one of our first patients in the Getafe hospital in Madrid, burn hospital, large surface burns hospital. These patients, these burns are not only extensive but also deep. Although you save the life of the patient to reconstruct the skin, you do that with cells of the patient himself in order to prevent rejection. The aesthetic effect is limited because the burns go beyond the skin itself. They are deeper than the skin. But when we have the luck of having not that deep and severe burns, for instance, in this case, a leg we can see that the aesthetic effect is very good.
And although this was initially designed for extensive burns, the plastic surgeons, little by little, took this technique to other situations, to other conditions, and also we are able to develop similar systems for oral mucosa in head and neck oncology, or to replace urogenital epithelium. And then we also had access to a significant number, a very high significant number of patients, especially patients with extensive burns. And therefore, we've acquired large experience in terms of the clinical outcome from the application of this skin that was done manually. And then we've come to think that this product was finished. So we got the patent, and we gave the license to another company to put it on the market, and then we started the next step. How can we go into auto mode, away from manual mode, based on away from the lab? This is growing very well. It looks very well. How can we automatize everything so that it may work non-stop? It was then when we decided to go to the printers, to the 3D printers. And what we did was that we automated the method that we had started by hand. And this is the key. We had the materials, the processes very well studied. And what we had to do was to automate the process. We were in an engineering school, so, well, it was likely. And there was no surprise. Any issue could be solved in a reasonable period of time. So the first thing we do with our printing is to print the dermis with fibrin, with fibroblasts. And once this is solid, then we print the first layer of the epidermis. And if we transplant this to a patient or to an experimental animal in the air fluid surface, the epidermis starts differentiating, forming all the layers. And then we get the complete skin. And from the real-life point of view, our printer has different components. Here you have the cartridges. And as you may see, these are syringes, sterile syringes from the hospital. We work with as many sterile components as we can. And these are coupled to high-precision engines that are directed by the software in order to extract the components, the bio-inks, to mix them or not to mix them, and put them into the area where tissue is being created. And these three cartridges here have the right elements to build dermis: fibroblasts, human plasma, and calcium. And this one here has the keratinocytes. So from these three bio-inks, we get the dermis generated, and from this here, dermis is created. So then in the air fluid surface, experimentally in the lab, in order to generate the tissues, and not yet it is being transplanted to patients, but for the time being, this is transplanted to immunodeficient mice that are not going to reject human skin, because what we are printing is human skin. And this helps us analyze what is working on in a similar situation as a transplant. And this is in mice. They are nude because they are immunodeficient and they are bald. And this is the human skin transplanted. And for us, visually, we are experts, and by palpation, we know that this is human skin, different from that of the mouse. This is histology. showing perfect human skin with dermis, with epidermis. Oh, okay, I think that the battery is failing. And the epidermis with all the layers, the stratum corneum, the point of union between epidermis and dermis, and with immunofluorescence, we may visualize a number of markers typical of skin for epidermis and dermis, showing that structurally this is human skin, actual, real human skin, bioprinted, and we've conducted different experimentations, for example, wound healing, and it behaves as human skin, indeed. And well, in our first bioprinter, this is a Meccano. It is a toy, and it is the work of one of our students of industrial bioengineering, a student of us. And this helped us to produce the first skins. And this was a landmark around the world because we were the first capable of using 3D printing to generate human tissue that is functional. And for the first months, what I did was to be interviewed by different international media, from Al Jazeera, journalists from Moscow, and progressively, gradually, we've reached the current prototype. And here you have the cartridges with the bio inks, here with color inks, in order to help visualization, in order to have the bio inks, the plasma cells. These are the engines. These are the engines that set in motion the syringes. And through these tubes, well, here we have the deposition modulus where the skin is formed. And now some conclusions. Well, this procedure now is beyond the field of expectation. Now we're reaching maturity where we are able to build real things and things that may be applied. The first application will be to reach the testing market for drugs and devices, and the regulation is simpler. This would be a drug. So in order to transplant, it should come under the authorization of the regulating agents in order to apply the regulation for drugs. And in order to produce the change, we must change the technology that is now at the experimental stage. We must go into industrial production. We already have designs for industrial bioprinters to be built. And in future, if all these new techniques could make progress, as we want them to progress, the transplantation, the bioprinting of skin products will be something that will be in our midst. So we must think of the factories of tissues and organs in future, because it is something that has not yet been designed. And about new opportunities we are working on, certainly so far we have interfollicular skin created, but now we want to design a more complex skin with melanocytes, with more structures, for example, follicles, glands, with extracellular matrix, which will be much more complex. And also we are working on validating all these models in order to use them clinically. And first, we will acquire skin, and we are thinking of other tissues additionally that will have a not complex 3D dimension, cylindrical vessels, blood vessels, urethra, 3D complex organs such as heart and kidney. It'll take about 10 years to get them to become a reality. And to conclude, something that belongs to the future, This is a picture you may find in Organovo's webpage, the company that for the first time put on the market 3D printers. And what they say, for example, if we want to do something about a melanoma on the face of the patient, there'll be an integrated device that is going to get image acquisition, 3D image acquisition, to decide what is the nature of the lesion. And also there'll be a magic scalpel that is going to do the ideal resection of the melanoma, and then the 3D bioprinter will come in with cells, loaded with cells of the patient themselves, and is going to print the skin. And this is sci-fi, I know, but Jules Verne already told us that sci-fi may move mountains. And also to thank all the people who made this possible, this project possible. Juan del Cañizo from Gregorio Marañón Teaching Hospital. He is a surgeon himself, but also he is a very good bioengineer as well, and he helps us a great deal to develop bioprinters. Indeed, it's his major contribution to our work. And I'll stop here. Thank you.
Muchas gracias, José Luis. Ahora.
Thank you, José Luis. Now I introduce José Antonio Lopez Martin, oncologist. He works at the 12 de Octubre Teaching Hospital, and he works in immunotherapy in oncology. You may know that this year the Nobel Prize in Medicine was given to an American group, a pioneer in immunotherapy in cancer. So this is very important today. And I asked José Antonio, please tell us why this is really disruptive if it already was there. It already existed. Why is it disruptive? Thank you. Thank you, José Francisco. It's a great pleasure to be here with you. And I want to share with you things that really fascinate me. And I don't want to get mixed up because I am really fascinated. Immunotherapy in cancer is not modern, but it is disruptive. It was 100 years ago, thanks to this surgeon, Dr. Colley. He reached immunotherapy because of failed surgery. He was a very good surgeon in New York City. And this was the beginning of the Memorial Sloan Kettering. This surgeon operated on an 18-year-old woman with a hand sarcoma. He knew that he had to amputate the arm above the elbow. He had to do that, and he regretted doing this. And the patient died out of pulmonary metastases, and this really marked his life, and he really got depressed. And he decided to do research in order to see what he might do to complete surgery in order to prevent mutilation. And in spite of mutilating, not changing the natural history of the disease. And throughout history, several surgeons had commented that their surgeons, after severe major surgeries, had severe infections. This was common. Poor hygiene, surgeons that would not wash their hands, the drapes that would not be changed in between patients, and those with major surgeries because of severe tumors that were infected, if they survived to the infection because there weren't good antibiotics, sometimes they would not relapse. So with that intuition that there was something in the battle of the body against cancer that might, in the end, protect the body, he invented a treatment with a vaccine. looking at what usually infected the patients, he got a mixture of things that usually occur on the skin. And he developed the first non-surgical treatment of cancer before radiotherapy and before chemotherapy. And this was really disruptive. And from then on, there was an enthusiasm stage leading to immunologic stages, the immune response to cancer. But it is to be regretted that in the 80s, from the 80s on, we reached a plateau. We had interferon, we had interleukins, even Rosenberg, another surgeon from the NHI in United States, had developed cell therapies taking lymphocytes out of the patients to be reinfused, superactivated, going against the tumor. But then we grew skepticism. We stopped talking about immunotherapy, but then antibodies, the new monoclonal antibodies targeted against tumor-specific proteins. And this really generated some excitement, reaching 2011. And it is in 2011 when the history of oncology changes. And thanks to important people I'll be touching on later on. What have we learned in these 100 years? We've learned a series of things. Up to the year 2000, we were really efficient in knowing the biology of oncology, knowing that cancer were isolated cells that would cluster, that would proliferate, and would produce mets. And molecular biology helped us understand the critical cells in every step and what would be their potential targets. But in the year 2000, we realized from what we've mentioned above, that cancer was not only a group of cells, but a group of cells interacting with the host, usually with fibroblasts, blood vessels, inflammatory cells. And it was the whole picture that we had to treat whenever we wanted to find the right strategy against cancer. And we got to know that amongst the different defensive reactions of the immune system, for example, inflammation, production of antibodies, or the production of cells that are specifically directed against other cells, the cell type immune system matters. Special lymphocytes, specially selected lymphocytes, will identify cells that behave strangely, and they'll be attached to those strangely behaving cells. And with this physical dialogue, because they are hugged, it is like it is a way of really producing holes in the attacked cell so that the attacked cell will bloat and will be destroyed. And this immune response goes through different stages, kind of different, and they are finely tuned. Immune response requires releasing something, because the immune system has recognized something that is foreign, and the foreign bodies must be assimilated by macrophages, and after that digestion, this information is offered to selected lymphocytes in the lymph nodes, and these lymphocytes are the troops directed against the antigen that is recognized. These are selected, activated lymphocytes going into the bloodstream, identifying nodes that are affected by tumors, by inflammation. They infiltrate the site and they attack the antigen, and they go into that deadly chemical kiss hug that means the destruction of the foreign cell. So this is a complex system, and each stage has a number of regulating pathways. And we've also learned that for any immune therapy to be effective against cancer, it must meet a number of common sense requirements. It must generate the activation of the lymphocyte. And then that activation must be followed by proliferation so that those selected lymphocytes will be greater in number and also have an advantage. And they must also be able to infiltrate tumors, releasing the enzymatic machinery to destroy the foreign cell. Now it's me having problems with the laser. And in these 100 years, this is what we've achieved. We've tried to stimulate this cycle in 3 ways, basically. The first one started by Coley generating vaccines. What for? In order to stimulate the afferent pathway, the entry of information into the immune system to generate immune response vis-a-vis these vaccines that potentially might be similar to what the cancer had. And secondly, the second step was to identify cells, usually from the patient themselves, and which are activated outside the body of the patients. They are amplified in number, and then they are reinfused. This is the passive cell transfer. And also, we've stimulated this loop by a number of substances that are cytokines that activate different steps in the proliferation, in the recognition, identification, and the attack of the tumor. And this is a stimulation, and then there comes the disruption. And we've learned that the immune system, when it generates a reaction, when it is on, it really kills, and it kills efficiently, as I've hinted at. And the nature itself has selected a number of mechanisms in order to produce that kill that is not incompatible with life, identifying what belongs to me. Don't touch what belongs to me, because that will be incompatible with life. And secondly, generating a number of systems, double identification, double recognition systems, generating a double check, a dual check system. Not always when a cell finds an antigen is going to react. We need much more concomitant stimuli, and this is what is called the T-cell receptor, which really identifies and attacks. And also there are co-stimulation moleculae, and it is the CD28, for example. And a number of years ago, we saw that when there is co-stimulation for immune response, at one day from co-stimulating, CTL4 would start growing. Nobody knew what it was about. People thought it was another co-stimulation molecule, but then another researcher said, no, it is putting a curb, because when it is on, it is also putting a curb. It is limiting. And as a matter of fact, when they identified the gene that produced the CTLA4 protein and blocked that gene, they saw that in the knockoff mice, it would grow a little, and when the mouse was a baby, it would die, and there was a massive lymphocyte invasion. So it was a blocking protein. So this is not a co-stimulation. It is a limiting. It is a CTLA4 protein producing a block. And we must understand this. The researcher wanted anti-neoplastic strategies, and he immediately, from his knowledge about CTLA4, immediately he helped oncology to make progress. And once the lymphocyte is on, and once it is in the bloodstream, the nature wants to put a limit because nature doesn't want something that is potentially dangerous blocked continuously. So this researcher, what he did was that when there was co-stimulation, there was a signal that would produce another molecule, PD-1, that would be bound to the PD-1 ligand, and that union would block the T-cell action. So two researchers understood that there were blocking pathways, and they understood that putting a curb on the blocking molecules could help to stop cancer. So we know from this that the immune system is lethal. It may produce massive destruction, and nature has selected mechanisms in order to ensure response is the appropriate in terms of the site, intensity, and duration, not to overdo it, so that for every action there'll be the right reaction to stop fires that would be continuing in the body. We've been talking about PD-1 and CTLA-4. Molecular biology in immunology discovered that there are many couples of ligands, receptors that come together, are associated between the lymphocyte membranes and the membranes of other cells in the stroma or in the tumor. And also they ascertained that these interactions are organized spatially in specific places of the membrane that at the end of the day will give the lethal kiss, the lethal hug between the T cell and the targeted cell. So this is what we've been learning so far. And we also know that the lymphocyte, once it is on, the tendency is to die, or well, I mean, that it'll be off. I am talking our own jargon, and sometimes we are imprecise. But in order to inactivate, there's induction of other molecules that are for co-stimuli. It's a large family of about 20 molecules with their own ligands. And as well, the tumor may adapt to the immune response, generating things that will stimulate the inhibition of the T cell. And this is known today. And as a consequence of all this, we have this data for you. This information tells you that after decades treating metastatic melanoma through immunization, through cytokines, through different immunotherapies, now we have the ipilimumab coming from James Allison's research, increasing survival rate versus the control arm. And also there's another molecule, nivolumab, anti-PD-1, or pembrolizumab, anti-PD-1, that show that they are even better than ipilimumab. So after years of being in the drought, now we have ipilimumab, and after 3-4 years, we had the next agent in order to leave ipilimumab behind. And this means that in a certain way, the tumor is foreign to the body, and the body identifies it but can't act because there's a deception, because it's masked. And if it's foreign, there are antigens, and antigens must come from somewhere. Usually tumors have a molecular system to produce new antigens, and one, for example, is changing the genetic contents by mutations. And we saw that those tumors that would be frequently mutating, melanoma, lung, bladder cancers, for example, were those that finally were responding to these immunotherapies. The largest mutational load the larger response capabilities. And the mutational load now is in the glossary, and now it helps us to go into the right, efficient decision-making. That is not only a mere diagnosis. It is beyond. It is the identification of predictive biomarkers that predict bioresponse, and also something else, something that is evident between the mutational burden and the likelihood of response using these drugs.
Talked about melanoma and PD-1, but look at what has happened in the last 5 years. Lung cancer, squamous, non-squamous, first line, second line, urothelial, renal, head and neck, lymphoma, and all this metastatic disease. And suddenly last year, high-risk melanoma in the setting, adjuvant setting. All this has been New England Journal of Medicine, and because it has generated an obvious benefit in gains in the overall survival. And this is changing the clinical practice and also the life of our patients, of course. And I've talked only about anti-CD4 and anti-PD-1, but all molecules that I have shown in a chart before, they all have drugs that either break or stimulate the core stimuli, and not only lymphocytes, also the NK cells, and not only the lymphocytes and NK cells, but the stroma components that are inhibitors of the immune response. We can combine with anti-angiogenics that are classical ones, but also with products related with the classical metabolism that were abandoned and that now are living again, thanks to this concept that the immune response is stopped and we have not to stimulate it, just remove the brake. And the next thing, see how we can combine these different strategies so that they act on multiple targets. There will not be one target whose blockade satisfies all the situations of the patients. And talk about combinations, we have the evidence of a combination that is greater than, that generates more benefit than the monotherapy. Nivolumab and the anti-CD4 anti-PD-1 is better than the anti-CL4 and PD-1 but separately. There are many experimental models that suggest new combinations that we will know within 5 years, more or less. And out of them, some that are already in the clinical setting, experimental clinic rather, as the anti-IL-1 with acetylase histone, the negative regulator, etc. Some have fallen back in spite of the clinical benefits. The epacadostat, we expected results in phase 3, was stopped last year, unfortunately, but we have many of them under development, as we will mention later. And we are also reviving the use of cell immunotherapy that consists in collecting the T cell lymphocytes of the patient, activate them ex vivo, proliferate them, and reinfuse them. Why are we doing that? Because we have known how to modify the receptors, how to modify the sensitivity against the tumor. We are able to generate genes, artificial genes that recognize specific antigens, or even completely artificial receptors that are chimeric because they have a piece of immunoglobulin, a piece of co-stimulus protein, and a piece of a kinase that generates the signal to the nucleus. This is what is called the CAR cells. CAR cells, there are 2 already approved. One of them that the industry has dared to do something that classically was academic before, isolate cells from an individual, expand them and reinfuse them, has always been something nearly handcraft. This industry has scaled up this procedure and makes it available to the whole community. There are important side effects, but mainly what we've got are cures of refractory situations, that is leukemia, 83% of complete response, or this lymphoma that previously was refractory, more than 70% of objective responses. We are redesigning the antibodies, monoclonal antibodies. Now we are able to do antibodies that recognize 2 antigens. If we make the antibody that recognizes an epithelial tumor cell and a T cell, physically they are going to be close together, and this can increase the efficiency of the cell due to the spatial neighborhood or vicinity. We have identified how the tumor cell has to die in order to release those antigens, so that those antigens can be recognized by the immune system in order to attack them. This is what is called the immunogenic cell death. And we also know, and this is important as well, that we can recycle our radiotherapies, chemotherapies, and antiviral and biological of the tumor to generate this immunogenic cell death and combine it with the new immunotherapies in order to make what the endocrinologists did and all the time. If we had rapid action insulin or slow action insulin, we combined them, and we have had a better control of the disease of diabetes. The rapid action insulin where the anti-target therapies, anti-IGFR, anti-HER2, and the immunotherapy are slow action, but obvious. If we combine them, we can have the benefit of both things. Unfortunately, what we had at the beginning was toxicity, but this is changing now with different combinations of biological therapies and immunotherapies, and in reality, we are facing a new era of treatment of cancer that is not surprising, and we are adding the intralesional treatments. There are tumors that the lymphocyte don't reach to due to different negative conditioning factors that make them not be inflamed tumors. If we inflame them, we can do that with chemotherapy, with radiotherapy, but also with intralesional therapy as viruses. Those viruses that are already marketed can be injected in the tumor. They generate, first of all, growth of a virus within the tumor cell, but secondly, the destruction of the virus and the attraction of cells that recognize the antigens released by, in this case, the melanoma, in order to produce an immune response, a distant immune response. I inject a lesion in a skin or a ganglion. We have an inflammation that takes place and an activation of a defensive response that can hypothetically control a metastasis in a site where I can't puncture, for instance, in the lung. And this is the landscape that is left now. We were here, and after the disruptive contribution of those two people, we do find many new indications with many new drugs, with more and more complicated names, by the way, with cells, with indications rather, for many physicians that are unknown, the Merkel cells or squamous skin carcinoma that we have never treated with drugs efficiently. Lung carcinoma has stopped being, well, it's still being the black beast, but less than it was a few years ago. We have been able to obtain some curious indications as this one. Any tumor that has microsatellite instability. Why? Because the microsatellite instability is associated to a repair defect that accumulates mutations. So it's the same. The histology, if I have that mechanistic abnormality, I can have a very high mutational burden I can't treat. But it's the first time that a drug in oncology has been approved, not against a tumor, but against the mechanism through which the tumor has an adaptation advantage. We have learned that sometimes the tumors progress during the treatment, but not because the tumor is progressing, but because they are getting inflamed and become bigger. So we have to talk with the radiologists, because it may happen that these progressions then are followed by remissions of the disease, and we have changed our criteria of response evaluation. So the oncologists have to be revising our way of assessing the patients with our radiologists. We have seen other toxicities as skin toxicities, gastrointestinal toxicities, liver toxicities, endocrine toxicities that first make us be recycling in our knowledge of internal medicine and also talk with other specialists in order to treat adequately our patients. We are trying to make in predictive immunograms, including what we know in models, variables as the tumor burden, the absolute amount of lymphocytes, how many lymphocytes are there in the tumor. We have to ask the pathologist. Sometimes it doesn't tell us if it's not the usual practice, etc. And with that, if it weren't enough, we are talking about tumors, etc. We now have the microbiome appearing, the microbiome that can also condition the response and the toxicity to immunotherapies. That means that we are in a situation right now of a clear progress and clear change that has had an impact on the survival of many patients already. And still there are things to come. There are more than 2,000 products under research and designed to modulate different targets. There are 3,000 active clinical trials. Look at all those trials in combination only with anti-PD-L1. We are talking about several hundreds of clinical trials in the current world. The burden of papers is increasing. We are 400 per year in PubMed, around 30,000 new papers a year that we have to try to know. So as a conclusion, we are in a new era of oncology thanks to molecular biology and to the intuition of some immunologists that has already had an impact on survival and that are making us reclassify our knowledge about the tumors according if they are more or less inflamed. And we have already many new drugs and combination strategies that are being developed. And apart from that, with also very favorable impact on hematological neoplasias, not only in solid tumors. So is this new immunotherapy of the cancer disruptive? I believe so, for all reasons I've said. But very important, we talk about streamlined concept. It's necessary to have more multidisciplinarity. We have to look in the public and private systems that we have to retrain ourselves because all these things are new, and all this thanks to those two people, as we've said before, that received, had that vision and did receive the Nobel Prize recently in physiology and medicine. Thank you very much.
Muchas gracias, José Antonio.
Thank you very much, José Antonio. If we have been speaking about disruption for precision, we have seen and what is the future of printing and the artificial production of organs. Immunotherapy, that is really a revolution in the treatment of cancer. But when we always talk about disruption and precision medicine, even those who are not physicians think about genes and gene therapy. How is this that has been announced for so many years that we're going to be able to control our genome? And here we are lucky to have with us Gloria González Aceguino-Laza, who is the director of the Department of Gene Therapy and Regulation of the Gene Expression of the Navarra University, and she is going to tell us about all this. We're eager to listen to you. Thank you very much. I would like to thank for this opportunity of telling you about the work that we do in gene therapy. And I believe that, well, I wanted to say that gene therapy is a reality that is already here and to stay. And I think that José Antonio has already introduced that, because the CAR T cells are gene therapy and the oncolytic virus are gene therapy as well, because gene therapy consists in the genetic modification of the cells in order to fight some disease. And what we do with the CAR T cells, it's just infect them with a virus so that it expresses a protein that is going to give it a therapeutic property to those cells. And excuse me if I'm very simple when I present the data, or easy, but I like to put into context where the gene therapy is born and what it's all about with respect to the basic mechanisms.
No.
Well, when do we start talking about gene therapy? The gene therapy, we start mentioning it in the 50s when we do discover how the information is contained in our cells that is going to drive how we are. As soon as we know that the molecule that keeps our information is the DNA, we started talking about gene therapy because we see its potential to correct specific diseases. And I like to compare our DNA with a informatic program or software. There are not so many differences. The DNA contains the computer program that our cells are able to interpret as a computer program is interpreted by a computer. And in our case, what it gives rise to is to proteins, and now we know that apart from proteins, it also gave rise to many RNA proteins that have a very important function. This is the DNA. The DNA is an extraordinarily simple molecule. It's made up of 4 different molecules. I believe that we all know them since school: adenine, cytosine, guanine, and thymidine, that do have to be in a very specific order. And hence, there is a quid of this question. How these 4 molecules are ordered, that's how it is translated in a specific information. We have around 3,200,000 molecules in each one of our cells, and they are going to give rise to approximately 20,000 genes. And this is what, until 10 years ago, we thought what was the important thing, the genes that were going to give rise to the proteins. Now we know that 90% of our genome doesn't give rise to proteins. It does give rise to other molecules that do regulate the function of these proteins and are as important as the proteins themselves in the development of the diseases. Until 2 days ago, we thought that this was garbage DNA, and that's how we called it as well. So this order, as I said, has to be very specific and precise, can have some variability, and this makes that in this room each one of us are different. This is what gives the variability to the human being and to all the living organisms. And normally this works fine. Normally this variability does only give rise to phenotypical differences, but sometimes this variability can give rise to, in a sequence, in a simple nucleotide, that then results that we don't have the correct protein that is being formed, or the protein that is produced is not a functional one. And that's when we start talking about diseases. In fact, the difference, for instance, between those 2 children and this other child is simply the mutation in one single protein. And this has very important consequences as the ones we see on this picture. The rare diseases, at present there are around 7,000 genetic rare diseases that have been identified. And with the technology that is growing and the recompilation of the information, this can only be growing more. In many cases, these diseases affect one single gene, involve one single gene, but each disease is very little frequent. That was it. They are called rare diseases. But all in all, we see that each out of 2,000 births, one of the children that are born is born with a rare disease. So there are 300 million of people involved with a rare disease in the world. And what is even more important, the rare diseases in their own majority lack treatment. Normally, they start in children, in small children, and in many cases, as they lack a treatment, those children die. The treatments that do exist in most of the cases are palliative treatments. Once again, we go back to gene therapy. We knew it was the DNA. We knew that it contained our information. We knew that it was the causing agent of these diseases. What can we do with that now? Well, as I said, the DNA is an extraordinarily simple molecule and very easy to manage or to handle. In fact, in the lab, we are able to purify DNA from our cells in a very simple manner. But this DNA, we can place it in a filter paper, send it to Japan, and in Japan they are going to be able to salvage that DNA, and it will have exactly the same sequence that we have sent. What does that mean? That we can manipulate very easily this DNA, and in the 60s and 70s we were able to develop a series of tools that allowed us to cut and paste those sequences of DNA. With a certain information, we are able to generate a different information. It's like to making a film. You are recording or meters and meters of film, and then you are going to do the editing of that material, and with the same information you can generate different films. So that the gene therapy is based on that. It's based on using that genetic material that we can develop in the lab as a drug. And we have different modalities here. I'm going to focus fundamentally on two of them. One is the adding genetic material, introducing in the cell a correct copy of the gene that is missing without eliminating the one that is defective or doesn't work. But now we have reached a new area on the gene therapy period that, in my opinion, is fascinating, that we are going to be able to correct our genetic material. We are going to be able to go and say that gene is defective and correct it in a specific way. And this is going to be achieved with a series of nucleases that have been developed in the last years. But which is really the most limiting part that we have for the gene therapy? One of the most limiting parts of it is to introduce this. We know that what we want to introduce. We know what gene is missing in the patient. We know that we want to introduce it in a given cell. And how do we bring it to the core of the cell so that it is able to produce the protein that we want to be produced? Well, nature has given us the tools. We didn't need to create nothing too innovative. What we do is use viruses, because everything that the virus do, and this is the only thing they do, is they transfer their own genetic material to our cells. If the viruses don't infect and don't transmit the genetic material, they are not going to be able to replicate and propagate. As I said, we are able to manipulate the genetic material, our own, and the material of the viruses as well. What we do is what we are doing is that we take the genetic material of the virus, we eliminate from those virus those genes that are going to give rise to proteins that will be associated with the pathology produced by that virus, or those proteins that are involved in its replication. We eliminate it, so we make room there. And what we do is to introduce the genes that we want to express in the cells. And that's how we create viral vectors that are going to allow the transport or the transfer of this information. The gene therapy has several modalities, as I said before, with respect to what's the material that we're going to be working with, but also how the delivery mode is. We have a gene therapy that we can give directly. We can inject the virus, the therapeutic virus, directly in the organ. For instance, in the case of the treatment of Parkinson's disease, we can do gene therapy with a direct injection in the brain. For hemophilia, what they are using is injection in the liver for the production of the clotting factors, but we can also extract the cells from the bone marrow, infect them with the virus, and return them to the patient. For instance, in the case of epidermolysis bullosa, one of the strategies that is being used is that I'm going to take out the cells of the skin of the patient in order to prevent the potential rejection. But before introducing them again, I'm going to infect those cells with a virus that will bring the protein that is missing in this patient, so that the skin that we are going to put again in the patient is perfectly functional. Among the viruses that we use, some are very well known from all of us. The lentivirus, that are RNA-derived virus derived from the AIDS virus. We have converted a virus that has been really terrible for the world health into a virus that is going to allow us to cure. In fact, it's the one that is being used to do the CAR T cells. And then we have other viruses, the DNA virus, more or less complex one with higher or smaller capability to introduce material genetic material, and all of them share something that is very important in the case of the treatment of rare diseases. The rare diseases are genetic deficiencies that are going to last forever in the patient, for the whole life. So we need a virus that once we inject them, they have to stay ideally throughout the whole life of the patient. The therapeutic effect has to be forever. I'm going to focus on the adeno-associated virus, AAVs, because these are those that at the level of injection in an adult patient are obtaining the greatest success, and they have a highest safety profile as well. And this is due to the fact that this virus per se has features and safety profiles that are very important. It's a very small virus of DNA of 20 to 25 nanometers, and it's very important to know that those viruses are naturally deficient in replication. This means they lack the problem that once you inject it in the individual, the virus starts replicating and expands and goes to other individuals. It's transferred to other individuals. For it to replicate, it needs that the same cell that has been infected has to be infected by another virus that can be, for instance, an adenovirus, a herpes, or a vaccinia. Then it has another property that is very important as well. They are not pathogenic. In this room, we are all, practically all, infected with AAVs, but we haven't gone to the physician for him to give us a treatment because we have an infection with this AAV. Why? Because it doesn't produce any sort of pathology. So already from the wild virus, this virus is a very safe one. And how can we make a virus of gene therapy then? Well, as I said, what we do is that we remove the proteins or the genes of the virus, and we put in their place the genetic therapeutic material, as simple as that. The only thing we need is that then when we produce the virus has to recognize that this is a genome of the virus. It could be its own. The only thing we have to do is to maintain this sequence here, this terminal sequence, and then the virus believes that this is his own genome, its own genome. And how do we do that in the lab? Well, we have the therapeutic genome that has the sequences of the virus, and we introduce it in cells in which, apart from including this, the therapeutic genome, we are going to introduce the proteins of the virus that it requires to complete its replication, so that after 72 hours that this process takes, the only thing that we're going to retrieve here as a virus are viruses that produce the therapeutic material. The AAVs have also another characteristic that makes them very, very interesting, as you will see. If I change the protein that is forming the capsid of this virus, that is a very simple one. It has one single protein in the capsid. Changing the capsid, what we call using capsids from different serotypes, I obtain different viruses that do have the capability of infecting different cell types. That's why those viruses can be used to treat diseases that involve the brain or the liver and a lung, etc. And this is a demonstration as images of how I can say, well, I have a disease, a hereditary disease that is involving the retina. In fact, my patients are blind because they lack a very specific protein in the retina. And I say, well, what virus am I going to use so that I can deliver that gene to the patient? Well, you can see here these are AAVs of different serotypes, and it's quite clear only according to the intensity of the expression of the fluorescent protein that I include in it that I'm going to have to use this serotype that is serotype 2. And if I have to treat a hereditary disease that is involving the cochlea, well, as you can see here, this is an experiment once again with different serotypes, and the 2 here is not good for this situation. I will have to use the ANC80. It's a serotype that is with this brings this genetic material to this type of cell. But this is only used in animals. This is something that is still at the experimental level. No, well, this is what I wanted to come. After all this developed after many years still of having been improving the gene transfer and everything that is still to be done, now the gene therapy is a reality. Yes, it is curing patients. In fact, in hemophilia, results both in A and B are spectacular. Patients without receiving factor VIII or factor IX recombinant for more than 2-3 years. Hereditary blindness, as you know, is the first product of gene therapy that has been marketed in the States. Spinal muscle atrophy, that is also one of the greatest landmarks, or Duchenne's muscular dystrophy. All of them with the same virus, the same AAV, but in each case in a different organ.
And now going down into detail, this would be the case of a disease which is hereditary blindness because of lacking this protein RPE65 in the photoreceptors in the retina. Well, these viruses have been injected into the retina of patients so that they recover sensitivity to the light. And this would be the outcome in this specific patient. This is before the treatment. This is the treated eye. You see how it recovers light sensitivity very soon after that treatment. And this would be the control eye, the non-treated eye. And after 1 year, it was treated. And you see that after the treatment, this treatment recovers the light sensitivity. This may already be prescribed. If you meet someone with hereditary blindness because of lacking this protein, then it might be delivered. We may talk about other situations. And when we talk about the impact it has in families and on the patient, this is one of the most recent outcomes that have really had an impact on me. This is in the case of the spinal muscle atrophy. It is because of being deficient in SMN1. Motor neurons may not survive. So these patients usually won't survive at 2 years of life. Okay, so this is the outcome of this clinical trial. And here you have the patients not treated, the historic controls. Only 8% of children go beyond 20 months of age without any respiratory problem, whereas here, these children who were in the study, they could survive beyond that barrier. And if we read this paper, 11 of 12 patients may be sitting without help for 5 seconds, 10 for 10 seconds, 9 for at least 30 seconds, 11 maintain the head up, 9 of them may turn around, 2 may walk on 4 and stand up and walk, and 11 could talk. None of the other arm of the historic control arm could achieve these landmarks. And this is one of the treated girls with 3 years of age. And you see that she seems to be perfectly normal. And now, very briefly, because we don't have clinical data about using these tools for gene editing. But, well, gene therapy still has a road in front of it, but we know it is already with us, that there are diseases that may be treated with add-on gene therapy. This is the future, to reach the genome in order to identify the sequences that are not correct in order to redress them. And then we have the nucleases, zinc finger, that were discovered 20 or 15 years ago, and CRISPR-Cas. And you may have heard about CRISPR-Cas, and you in Spain must be proud because the first one to discover these molecules is Francis Mujica. I hope that he gets to be granted the Nobel Prize in the coming years. And these are proteins, when linked to a sequence identifying specific sequences in the genome, the guiding RNAs take nucleases to the area of the mutation. And if at that time there's been the delivery of a recombinant DNA that carries the right sequence, we may correct the disease. And although CRISPR-Cas are not yet in the clinical setting, the Zinc finger are already in the clinical setting. The first clinical trial took place at the end of last year in the case of MPS type 2. And these patients accumulate a larger number of glycosaminoglycans, dermatan sulfate, heparan sulfate, producing tissue damage, organ damage, and this is why they die very early in life. And well, this company, well, it is a company devoted to gene therapy, and they've used the Zinc finger, delivering the Zinc finger that cuts and gets the right mold, and this gene material will be delivered by means of AAVs to be administered to the patients. And this is the latest outcome published in September, last September, in the follow-up of these patients. This is a study, this is a safety stage 1, stage 2 trial in order to study the dose escalation in order to check any side effects, not to overdo the dosing. And here the cohort with a low dose, we don't see changes in dermatan sulfate nor in heparan sulfate. But in cohort 2, at a higher dose, a slightly higher dose, apparently we get levels that are below the line. We still have to do a longer follow-up of the effects of this treatment, because these patients kept on receiving the deficient enzyme by means of infusions. It is important to know that there was a very high safety profile. And the issues in gene therapy, one of them, that we need to reach a significant number of cells in order to correct them. So we need efficacy. And another issue we encounter, which is really severe because it's been a bottleneck for us, it is the production of the virus. The clinical grade vector, well, in the lab, it is easy to produce. But in the clinical setting, with the right clinical grade in large numbers, this is really difficult. There aren't many places around the world capable of doing this. So also, immune response may be a limiting factor because we may produce antibodies, and also the issues that have to do with the wrong integration of the virus in the unwanted sites. But data keep telling us that apparently this integration problem would not be limiting this therapy, because we've been able to limit the off-target or integration issues. It'll be really important, not only in gene therapy, but also in other disruptive medicines. And it is a cost. It is really an issue. They are still very, very expensive. And we need to keep on working on lowering the price so that it may be provided to the population at large. So these are my conclusions. Gene therapy represents healing genetic diseases. Gene therapy is a reality, and as any medical reality, it must be on the market so that it becomes real. And also, for sure, there are a number of limiting issues that keep it from being generalized. I'll stop here. Thank you for your attention.
Bueno, tenemos tiempo para un par de preguntas.
We have time for a couple of questions. Well, I have the glare. I can't see you. Well, I see many hands up, and I don't know who to choose. And I also wanted to ask a question, but I don't know whether I'll be able. Well, first, I want to thank you, because these are themes, these are topics that seem to be usual themes for us who are in the medicine field. But you've been very good, very didactic. Gloria, I don't know whether this disruption is not well understood. At the end of the day, gene therapy has been concentrated around rare diseases and processes where research has gone to the underlying problem. And I see that the whole set of diseases the patient suffers from are not connected with gene therapy. But gene therapy has only been directed to rare diseases, orphan diseases, where no investment has been provided largely. So what would be the role of gene therapy outside the orphan diseases? Well, probably the main problem is that this is innovative medicine, and we must weigh the risk-benefit. Yes, there may be diseases such as diabetes where gene therapy might have a role. But if I say you take a pill or I deliver a virus, well, we still are afraid of getting a virus delivered into our body to be healed, and a virus is still associated to diseases. So we still have to show that gene therapy is really safe. And when that day comes on, then we'll be able to cure other diseases. Any other question? Comments that you'd like to make? Well, we're running behind our program, so I think that we'll adjourn here. And I want to thank you for your participation. And now at the coffee break, please enter Twitter and look at our hashtags so that you give your comments. And in about 20, 25 minutes, be back, please.